Okay, members, let's get ready. We now move on to questions for the Minister of Health, and we'll start with listed questions. Questions 2 and 7 have been withdrawn. I call on Danny Baker. Danny.
Question 1.
Minister.
Deputy Speaker, with your indulgence, before I answer the question, I just want to acknowledge that I came across a social media post from Mr Baker last night, marking the 2nd anniversary of the sad passing of his nephew, Enda, a baby who succumbed to a genetic disease called Edwards syndrome, and I believe that's not the first time for the family. So I just wanted to acknowledge that and reach out. And Deputy Speaker, as I often say, health is personal. In answer to Mr Baker's question, my department has always and continues to support the promotion of self-directed support, as it allows an individual to have as much choice and control as they wish over their personal budget. A personal budget that has been identified and allocated to them by our local trust to meet their assessed needs. On the 1st of April 2024, my department announced the uplift of the regional hourly rate for direct payments by 9.8% to £16.88 per hour, and that's from the previous £15.37. It's a set regional rate per hour, and therefore this is the rate all trusts give to an individual in receipt of a direct payment. I'm aware that there can be a disparity in the rates paid to personal assistants. However, the rate of pay is ultimately a private arrangement between the service user and the personal assistant that they employ, and on that basis the rate of payment to the personal assistant is negotiable. The service user, as the employer, is responsible for meeting all the administrative costs associated with being a recipient of a direct payment, such as national insurance contribution, pension contribution, sick pay, annual leave, redundancy and so on, all from within the direct payment amount which has been allocated to them. Over and above this, my department would endorse that personal assistants receive a rate of pay that is, as a minimum, reflective of the national living wage, which is £11.44 per hour.
Thank you, Minister. I call on Danny Baker for supplementary.
Minister, and thank you for the kind words. How does the Minister plan to ensure that organisations such as Kids Together are able to continue and provide an invaluable service where managed budgets are paid at the same rate as self-directed support?
I thank the member for his supplementary. I think one of the points is that a direct payment is not intended to replace existing support offered by family members, but rather there to supplement care. So there are a range of people who are providing this care, and it's important to think that all of them get a fair crack, as it were, of providing that support. So I will be working with officials and asking them to look closely at ensuring that there is a fair and equitable spread of those who are providing that care. If I may, Deputy Speaker, when I think about this, I always remember my time as a Victims Commissioner and the move that was made from the Northern Ireland Memorial Fund to the Victims and Survivors Service. And the point about that was the move was to truly personalise the service. So the Memorial Fund used to offer programmes like back to school or short break, and if you wanted money for school uniforms for your children or grandchildren, all well and good. If you wanted a short break, all the better. But sometimes if you didn't want something that came into a scheme, the Memorial Fund simply could not help you. And so the move to the Victims and Survivors Service was designed to treat each and every client individually. What is it that is going to improve your life? What are the barriers to you being content and prosperous? And how can we come in and try and remove those barriers? And it's the same with these payments, and who delivers those payments should be the ones that the recipient who is commissioning the services feels is best placed to help their lives.
I call on Danny Donnelly.
Speaker, and thanks to the Minister for his answers so far. Will the Minister meet with the Centre of Independent Living to discuss their priorities around self-directed support?
Minister. Yes, I'm more than happy to meet anybody who has ideas about how we can best deliver these services. Absolutely.
I call on Tom Elliott.
Thank you, Deputy Speaker, and I thank the Minister so far. I understand and recall that there was something in the region of 70 million support package previously announced earlier this year. I'm wondering if the Minister can provide us with any information or an update of how much of that was for self-directed payments.
Minister.
I thank the member for the question. Yes, indeed, 70 million was announced by Minister Swan back in March. I can tell Mr Elliott 7.3 million was the figure invested into self-directed support. This was estimated based on current expenditure levels for self-directed support within health and social care. So I hope you would agree with me that was a very significant contribution to improving that service.
Thank you, Minister. Question 2 has been withdrawn. Call on Stephen Dunn.
Speaker.
I thank Mr Dunn for the question. In October of 2022, a draft Northern Ireland Road Safety Strategy reaching up to 2030 was published. While supported by departments at the time, it unfortunately could not be finalised due to the absence of a Northern Ireland executive. Following the return of ministers, the strategy has been updated and it was brought to the executive on the 23rd of May last. I support this strategy. I welcome the ambition to deliver an interim target of 50% fewer deaths and serious injuries between that decade of 2020 and 2030. The post-crash response pillar aims to establish an effective and appropriate response to collisions to help ensure road victims receive appropriate medical care and rehabilitation to minimise the severity of long-term impact of their injuries. The strategy identifies several key factors required for success in delivering the outlined 2030 targets and strategic outcomes, and I'm pleased it has secured executive commitment. However, this needs to be followed up with appropriate funding, appropriate resources and collaborative partnership working, for which I tell the member I will certainly play my part.
Thank you, Mr Deputy Speaker, and thank the Minister for his answer and his commitments. And I wish to put on record my gratitude to our emergency services who deal with such awful circumstances. Would the Minister commit to working alongside both the Infrastructure Minister and the Justice Minister to ensure every effort is made to meet these targets of 0 deaths and serious injuries by 2050, including looking, where possible, to improve the emergency service response times to road traffic collisions?
Minister.
Well, I would certainly make the commitment to work with the executive partners. I would also say to the member that I'm more than happy to work on a cross-border basis, because on Thursday not only was I at the health sectoral meeting, I also attended the sectoral meeting on infrastructure with Minister John O'Dowd, and his counterpart in the Government of Ireland, Eamon Ryan, said that statistics south of the border are also going very much the wrong way in terms of fatal road traffic collisions and collisions with serious injuries. So cooperation is also part of the mix. In terms of improving waiting times, my department has taken a number of steps to improve waiting times at emergency departments. Reducing handover delays in emergency departments has been a key priority, and a regional process has been issued to all trusts for the release of ambulances for outside emergency departments when the ambulance service is an outstanding Category 1 or Category 2 call, and I think this will very much improve response times. That is certainly the ambition.
Thank you. I call on Robbie Butler.
Thank the Minister for his answers thus far. Would the Minister agree with me that an opportunity has been lost with the failure to deliver the Desert Creek Tri-Service Training College, which would have assisted in emergency response times, given that road traffic accidents are a multi-agency response? And can the Minister explain what supports are provided for first responders after they attend these traumatic incidents? Thank you.
Minister.
And I thank the member, and I actually look forward to visiting Desert Creek to see what the Fire and Rescue Service are doing up there. Their employees regularly encounter incidents which may be defined as critical, and such incidents can cause psychological distress to those involved. And the Fire and Rescue Service is committed to ensuring employees receive the support required through critical incident stress management. The Northern Ireland Fire and Rescue Service is a comprehensive and integrated multi-component approach through that critical incident stress management to crisis disaster intervention. The aims they have are stabilisation, symptom reduction, return to adaptive functioning and facilitation of access to continued care. And as part of this process, employees are also offered the opportunity to attend counselling with Inspire. The ambulance service community resuscitation education officers have received training in critical incident stress management and will engage with community first responder volunteers if they require support following a challenging call. And if further support is required, the community resuscitation education officer can refer the community first responder volunteer to the Northern Ireland Ambulance Service peer support team. The Northern Ireland Ambulance Service peer support team can also refer community first responder members for free and confidential support through Inspire Workplaces.
Thank you.
I thank Paula Bradshaw for her question. As you'll be aware, junior doctors in Northern Ireland are employed under the single lead employer. They work in a number of host HSC organisations who are responsible for developing, issuing and monitoring the working patterns and rotas of junior doctors. Under the current guidance, it's recommended that trainees receive their rotas a minimum 6 weeks prior to taking up post. The Northern Ireland Medical Dental Training Agency is responsible for providing the postings to host organisations following the completion of their recruitment campaigns. NIMDATA has confirmed that all allocations for August of this year have been released to employing organisations, giving adequate notice to enable HSC trusts to prepare and to issue their rotas. I've been advised by the host organisations, the trusts, that they're making every effort to provide their junior doctors with rotas 6 weeks prior to the trainees taking up their posts. They have, however, advised this is not always possible due to vacancies appearing on the postings at late notice. In cases where the host organisation is unable to provide a rota within the recommended timeframe, they state that they advise the trainees and will, where possible, provide an indicative rota.
I call on Paula Bradshaw for supplementary.
Thank you, and thank you, Minister, for the response. I suppose when you engage, and I'm sure you have on many occasions since you've taken up post, with the junior doctors, that they have a long list of issues that they would like to see resolved, not least in relation to their pay. I'm just wondering, could you give an outline of how you've engaged with them since coming into post? Thank you. Minister.
And I thank the member. Indeed, I engaged with them before coming into post when I was the Assembly Private Secretary to Minister Swan. More recently, I've written to all 3 branches of the BMA and invited them to meet with me to discuss the issues that the health service is facing and how we can move forward together. I've also advised that I wish to meet all 3 branches together. In terms of the Junior Doctors Committee, they've written to me separately, and I hope to meet with them also shortly. I've reiterated my offer of arbitration, and I've confirmed my desire to see a revised contract and terms and conditions for junior doctors as a way to secure any additionality to the pay bill. The Junior Doctors Committee have stated that their current mandate is for pay and that contract negotiations are something they'd consider once a reasonable pay offer and commitment to full pay restoration has been given. One of the non-pay issues that I believe we can make good progress on is in meeting the good practice requirements of delivering those rotas within the 6-week time frame. There are other non-pay issues that I'm keen to discuss as a way of improving the working lives of junior doctors. So, in brief, I say to the member, we seem to find ourselves in a situation that for me is a model illustration of why we need arbitration processes. So again, I take this opportunity, Deputy Speaker, to encourage the BMA Junior Doctors Committee to engage in those terms.
Thank you. I call on Liz Kimmins.
And I thank the Minister for his answer in relation to this issue. However, I think the fact that we're still talking about non-pay issues as the predominant factor concerns me, as the BMA have said very clearly that they need to see an offer in terms of pay. If this doesn't work, Minister, what is the next steps in this process? Because we need to find a resolution and we need to find it urgently.
Minister.
Well, I thank the Chair for her comments. Next steps are difficult because, as I said to Mrs. Bradshaw, we're in a classic situation where I think arbitration is the only way to go forward. If I were, as Minister, to go forward with the BMA Junior Doctors Committee on their terms, which is purely to discuss pay, there would be no guarantee, of course, that we would reach a mutually agreeable resolution, particularly given the budgetary constraints that I'm operating under. But the other point would be, how repercussive would it be to reach a pay agreement with the junior doctors, given the sort of quantum that they wish to achieve in those negotiations. So I can only say that I'm not currently looking at a plan B. What I'm doing at the moment is really encouraging them to sit down with the department and engage in meaningful, constructive and equitable arbitration.
Colin Newland-McAllister.
Minister, I don't understand how you can arbitrate on something where you're saying no already before you enter into such arbitration. So I think you've just outlined that the Department of Health's perspective is that there will be no discussions around pay unless you get discussions around contract. As the Minister, it would be incumbent upon you to actually sit down in a meaningful way with just pay on the table as well, without saying no. So what is there to negotiate if you're already saying no?
Well, I thank the member for her question. It is the terms and conditions of employment. It is the rotas. It is all the wraparound that is involved with being a junior doctor. And I don't for one moment think that junior doctors want to be junior doctors just because of the salary band that it offers. I think it's a vocation. I think they probably have very good ideas about how to improve the National Health Service, how to improve productivity, how to achieve better outcomes. There is an awful lot to discuss, and I think it's perfectly reasonable to say that the department is willing to discuss pay within the envelope of their terms and conditions, and that we would do so in a manner of independent arbitration.
Thank you. Colin Harry Harvey.
Thank you, Deputy Speaker. That'll be question 5, Minister. Thank you.
Thank Mr. Harvey for his question. I am aware of the workforce challenges that exist across health and social care, and I welcome the Royal College of Radiologists report. I've already agreed to meet representatives to discuss their findings in some detail. The College is an important stakeholder in delivering effective cancer and imaging services for our population, and my department is committed to developing cancer and imaging services for all the people of Northern Ireland. Following on from the cancer strategy, by this year we will have invested £10.88 million to stabilise HSE's Trust's oncology and haematology services. This will increase the number of funded posts relating to oncology and haematology, including clinical oncologists. Specific cancer pathways are currently being developed, which will inform future strategic workforce planning to address workforce requirements for clinical oncologists and other professionals. The active expansion of multidisciplinary teams is a key part of our overarching programme to reform health and social care. With respect to imaging services, my department and the HSC are taking forward a proposal for a multi-professional imaging academy for Northern Ireland. This would significantly increase capacity within the health and social care system for training greater numbers of radiologists and radiographers each year, including interventional radiological consultants. It will provide a continuous supply of locally trained consultant radiologists and advanced radiographer practitioners, and that will address the increasing demand for imaging investigations and reduce our reliance on costly outsourcing. I remain profoundly dissatisfied with the level of funding being made available to my department, which has hampered and limited the department's ability to make further progress that can transform the delivery of health and social care in Northern Ireland.
Harry for a supplementary.
I thank the Minister for his answers thus far. And Minister, I was going to ask you what plans you have to increase the number of specialty training places to ensure we have a pipeline of new consultants, but you have touched on that. Maybe you can elaborate a wee bit more on. Thank you. Minister.
I thank the member for a supplementary question. We do indeed have significant gaps across key professions within health and social care. Recruitment and training and retention of staff is critical. We also need to ensure that we're recruiting staff with the correct skills to deliver a modern cancer service. My department is committed to creating safe, adequately staffed work environments that will help to ensure that we attract and retain staff across the health and social care system. Through effective workforce planning, we will ensure that sufficient resources are allocated for the education and employment of health and social care staff. The Royal College of Radiologists 3-point plan to support oncology and clinical radiology focuses on recruitment, training and retention. My department's Health and Social Care Workforce Strategy 2026, Delivering from Our People, and its current second action plan contains a comprehensive and ambitious work programme that includes the development of initiatives to enhance our attraction, recruitment and retention across all staff groups and specialities. And I look forward to engaging with college representatives on this at our forthcoming meeting, which will inform our work in this area.
Thank you. Colin Allen Chambers.
Thank you, Deputy Speaker. Can the Minister provide an update on what has been done to speed up access to diagnostic services for patients who are suspected to have cancer?
Minister.
I thank the member for his supplementary question. The Department is working closely with Health and Social Care Trusts to address the long waits that we are seeing in many of our cancer pathways. This includes short-term measures such as buddying arrangements, whereby patients are transferred to other trusts for a diagnosis. Medium and longer-term measures are also required to ensure that we have sufficient capacity to meet the growing demand that a growing and ageing population will generate. This will require investment into workforce and capital equipment. It will also require us to transform how we deliver key services to ensure that they have the capacity and the expertise to deliver.
Thank you, Minister. I call on Connie Egan.
Question number 10, please.
Sorry, Connie, it had been indicated to us on the desk that you were going to ask a supplementary.
Deputy Speaker.
Well,
Deputy Speaker. Minister, I know that you will agree with me that early detection for cancers is extremely important, and recently I met with Cathy Brokenshire, the wife of the late James Brokenshire. We don't have early screening for lung cancer in Northern Ireland, despite it being one of our most prolific killers of people with cancer. Will you look at the idea of having screening for lung cancer and come back to this House with some proposals in relation to this really vital aspect of healthcare?
Minister.
Well, I thank the member for her question, and yes, I will commit to taking that away and discussing it with colleagues in the department. I think it is a gap that, I agree with her, not only exists but needs to be closed for the sake of our people.
Thank you, Minister. Colin Sinead McLaughlin.
Question number 6, Minister.
Minister.
I thank the member. So the Health Inequalities Annual Report, which was published by my department on the 27th of March this year, highlighted the scale of inequalities that continues to exist. For example, the report showed that in the years 2020 to 22, males in the most deprived areas live on average 7.2 years fewer than males in the least deprived areas, and the gap for females was 4.8 years. This a quarter of the way into the 21st century. Inequalities in health outcomes primarily arise because of inequalities in the conditions in which people are born, grow, live, work, and age. For example, research has shown only 20% of health outcomes are driven by the clinical care we receive, with the rest of the percentages related to the socio-economic and physical environment in which people live, and also by a range of health and lifestyle behaviours or choices. Making life better is the overarching strategic framework for public health through which the Executive committed to creating the conditions for individuals, families and communities to take greater control over their lives and be enabled and supported to live healthier lives. The framework is underpinned by a range of public health strategies which focus on specific issues such as substance use, suicide prevention, tobacco use and obesity prevention. It's further complemented by the integrated care system for Northern Ireland, which is underpinned by both a population health and outcome-based approach. Reducing inequalities in health is a huge challenge. It needs continued, sustained collaboration across departments and agencies, including local government, the community and voluntary sector, and with communities themselves to address the factors which impact on health and well-being locally and regionally. You'll be aware of my recent statement in the Chamber that health inequalities will be one of my main areas as Health Minister, and I hope to be able to update the Chamber soon on an initiative.
Sinead McLaughlin for a supplementary.
That answer. There's also 11 to 15-year gap in healthy life expectancy between the most deprived areas and least deprived areas. The rate of drug abuse is 145% higher in the Western Trust than the Trust average. We really need interventions that are directed towards those areas that are most deprived. And do you agree that the activity in your department goes hand in hand with economic performance? And how can we have confidence that regional inequalities can be tackled if the two departments are not working together in relation to regional balance?
Minister.
And I thank the member for her question. I think there are two areas here. There's the question of tackling areas of deprivation, and then there's also the question that the member raises about regional inequalities, and I'm certainly up for tackling both. I am working with departmental officials, as I say. I hope in the coming weeks to advance the initiative I want to bring on in terms of tackling health inequalities. Indeed, I have a meeting with senior officials scheduled for later this afternoon, where we take the next step in developing those proposals. And it's basically about, no matter where the area of deprivation is, that we take one or two, and we take services that already exist, and we put them into a programme, and then we target those areas. We kind of flood them with information and with services in the hope that we will have an impact. And if we do that, I believe other areas which suffer from severe health inequalities will look at what's been done elsewhere and say, I would like a slice of that cake. And as part of that, we will certainly be looking at ensuring that we deliver a proportionate degree of regional balance in terms of the rollout of this initiative.
Call on Linda Dillon.
And thank the Minister, and appreciate the answer to the previous question. I think that it's very positive to know that you seriously want to tackle inequalities. I think, given that response, do you agree with me that funding should follow need? So we don't need to reinvent the wheel. There are some fantastic projects going on that were funded through the Community Foundation, through funding from your department. Would you agree with me that that funding needs to continue? It needs to be implemented through the Community Foundation and through to those organisations that are working on the ground in those communities and understand the place that they're working in and the people who they're dealing with?
Minister.
I would very much agree with the member's sentiment. I think that funding needs to continue. I think while we can talk broadly about commonalities in terms of health inequalities, that each area of deprivation will have its own specific issues and its own specific needs, and is probably better placed, the community is better placed than anybody else, to say these are the solutions that we believe will work for us in our community. I should say that I have had very initial discussions with executive colleagues about this, just referring back to the fact that the solid research would say clinical and health interventions is probably only 20% of the solution. Maybe 40% is into socio-economic. And I was very pleased by the reaction of my colleague Conor Murphy, the Economy Minister, who seems to be up for tackling this. Because as a member of the Economy Committee before taking on this role, I was very focused on the fact that our rates of economic inactivity of people who are not in work or seeking work, it's actually about 26%. That's 1 in 4 people. And if you look at the reasons why people are economically inactive, health is probably the single biggest thing, both physical and mental. But accessible, affordable childcare, I think, is a major issue in there. So this is an all-executive initiative that we have to tackle, but not in a top-down way. I think we need to get into communities and say, do you agree that these are your issues? And how do we co-design and co-produce the answers that make a positive impact? Because those figures about how long you live and how long you live a healthy life, they're stubbornly not moving. The dial isn't moving, and we've got to change that dial. And to do it, it has to be a cross-departmental, all-government initiative.
I think we have time for one further short question. Stuart Dickinson.
Speaker. The cancer strategy, as the member will know, is a 10-year plan to reform cancer services here. Since it was published in 2022, we've already seen significant progress against a number of actions. Key examples include the development of rapid diagnostic centres and services to provide genomic testing for cancer patients. Both these services will help improve pathways and improve patient outcomes. We've also completed reviews of hematological cancer pathways and adolescent and young adult cancer services and are progressing work to implement the recommendations. We've also invested in oncology and hematology stabilisation plans and clinical nurse specialists to ensure the services are better staffed. Work is currently underway to review breast cancer services and to implement an optimal care pathway for pancreatic cancer patients. The focus of this work is on reducing the length of time these patients are waiting for diagnosis and for treatment, and therefore improving outcomes. I'll leave it there, Deputy Speaker, to try and afford Mr Dixon the opportunity to come back.
Mr Dixon, a short supplementary.
Thank you very much, Deputy Speaker. Minister, you'll recognise that skin cancer is one of the most common forms of cancer in Northern Ireland. You recently answered questions to me with regards to sunbeds. Would you agree with me that sunbeds are, as MPs in the House of Commons have described, killing machines, and what action will you take to ban them?
A short response, please, Minister.
Yes. Well, I hear what the member is saying. I can only say, Deputy Speaker, I've never been tempted to go anywhere near such a machine, and I will take it back to the department and I will revert in proper and appropriate detail to Mr Dixon.
Thank you, Minister. That ends the period for listed questions. We'll now move on to 15 minutes of topical questions. Questions 3 and 6 have been withdrawn. I call on Mark Durkin.
Mr Deputy Speaker, as the Autism Reviewer is a critical requirement of the Autism Amendment Act 2022, could I ask the Minister why this role has not yet been realised and recruited, and does he agree that it is critical to monitoring and evaluating the implementation of the new autism strategy?
Minister.
I thank the member for his question. I'm fully aware of the responsibility to appoint an independent autism reviewer, and I acknowledge the significant role the post will bring for autistic people and for their families. I have deferred a decision on the reviewer, and I've done that until I can consider health funding pressures in the round, which I have to do, particularly taking account of the outcome of June monitoring, which has now been announced. But I will take the decision on the reviewer in the coming weeks. I recognise the importance of ensuring all people with autism, or those waiting on an assessment for autism, their families and their carers, can all receive the right access to services. And I can assure all members that my department will continue to work in partnership across government departments, across the health and social care sector, across public bodies and the community and voluntary sector to make this happen. Whilst the monitoring and reporting role will be fulfilled by the independent autism reviewer in adherence to legislative requirements, until this appointment is made, the Department of Health will commit to this role. The Autism Strategy 2023 to 28 was published along with an initial 2-year delivery plan for 23 to 25 on the 13th of December last, and work's now underway across government departments and public bodies, and progress will be assessed through the annual monitoring report, which will be completed shortly. Once I've agreed and approved this report, a copy will be published on the Department of Health's website.
Thank you. Mark Durkin for a supplementary.
Mr Deputy Speaker, and I welcome that a decision will be made soon. I just implore the Minister to make the right one. Cognizant of the Minister's long-held interest in mental health and the absolutely appalling and disproportionate mental health outcomes for autistic people, would the Minister agree that we need to urgently provide specialist mental health support in that community?
Minister.
Again, I thank the member, and I want to acknowledge that the need for improved understanding of autism for all people has been raised consistently throughout stakeholder engagement and public consultations down the years. My department intends to provide autism training across all of the health and social care sector, rather than just empowering specialist groups of individuals. All trusts offer training and support to all staff in the effective support of those patients with communication challenges and barriers. That includes autism. When they are accessing services, support staff need to be more aware. Trusts do take a service-wide approach to addressing the needs of those with autism. This includes training for all staff, either run by individual trusts or commissioned from external organisations, as well as self-directed learning for those with a particularly identified training need. The Autism Amendment Act Northern Ireland 2022, Section 4A, states the autism strategy must set out how training, including accredited training, is to be provided to the staff of Northern Ireland departments and other public bodies on how best to address the needs of persons with autism and families and carers of persons with autism. The Department recognises that training needs to be provided which is readily accessible and practical in approach. It also needs to be influenced by autistic people to ensure that the challenges they experience are accurately represented. With funding allocated through the Autism Strategy of 2023 to 28, all trusts are currently taking forward a regional project to develop GP training videos. All trusts offer training and support to all staff in the effective support of those patients with communications challenges and barriers, including autism, when accessing services, while also supporting staff to be more aware.
Thank you, Minister. Colin Paul Frew.
Given the fact that we have had over 1,000 access deaths in Northern Ireland in the past year, and 755 in 2024 alone, that's deaths above the 5-year average, Minister. What does the Health Minister put these horrific figures down to?
Minister.
Well, I thank the member for his question. I acknowledge his long-standing interest in this area, and I think the first thing I want to assure him of is that the very expression of excess deaths is a rather horribly clinical expression, but I would also suggest a necessary one. And can I assure Mr. Frew that I do not want any partner, any relative, any friend of somebody who has passed away to wonder whether the implication is that that person was an excess death, with the implication that perhaps it should never have happened. So I am very much focused on the issue of excess deaths. It is, Deputy Speaker, of course, an area not unique to Northern Ireland. It's been observed internationally. The underlying explanation is likely to be multifactorial. Could include an increasing number of people with long-term conditions, such as cardiovascular disease, diabetes. It could be population lifestyle changes. It could also be access to services, or indeed the longer-term impacts of the COVID-19 pandemic. And this is something I have discussed with the Chief Scientific Advisor, Professor Ian Young. My department has also commissioned the Public Health Agency to carry out work to investigate the potential causes of this, and that work, Mr. Frew, is ongoing.
Paul Frew for a supplementary.
The Minister's movement in this issue with regards to an investigation into excess deaths, that's something that the previous Minister refused to conduct. But does he believe that lockdowns not only caused massive damage in development of our infants, the education of our children, the rising anxiety and depression of our most vulnerable, increased domestic and sexual violence, and increased child abuse, but also caused deaths?
Minister.
I thank the member for his supplementary, and I can very much, as a matter of principle, acknowledge the principle of what he is saying. But the impact of the COVID pandemic, the impact of lockdown, are all matters for this long and ongoing and necessary UK-wide inquiry, and I wouldn't want to say anything that would be considered prejudicial to the work of that inquiry. So I acknowledge what the member is saying. I understand the logic of what he is concluding, but I will stop short of making definitive comment for fear of prejudicing the inquiry.
Thank you. Tom Elliott.
Thank you, Deputy Speaker. And I'm sure the Minister recognises the significance of the modern facilities that there is at the South West Acute Hospital in Enniskillen. And I'm wondering if he would look at expanding the facilities there, particularly the theatres, so that they can be a regional hub and obviously be much more useful to reduce the waiting lists throughout Northern Ireland.
Minister.
Well, I thank the member for his question. You may recall that in another role as the leader of the Ulster Unionist Party, I had the pleasure of visiting the South West Acute Hospital not that long after it opened. It is a very impressive, very modern, very efficient-looking facility. And in terms of efficiency, the uptake and the capacity of theatres to do more, not just in the SWA, in the South West Acute Hospital, but I think the capacity and ability of all our theatres across our acute hospitals to do more is something I'm very much focused on, and that has to be a matter for debate, because I can't just wave a magic wand and increase the capacity and the usage of the theatres. But if I could, I would, and failing that ability, it's a question of negotiation and strategy as I see it.
Tom Elliott for a supplementary.
Thank the Minister for that, and I do note that he has visited the South West Acute Hospital in the past, but maybe it would be a good time now for him to update his knowledge, and I would invite him back to the South West if he would accept that invitation in the near future.
Minister.
Deputy Speaker, I am more than happy to accept an invitation to revisit the South West Acute Hospital and perhaps build a day's worth of programmes, of events, of meetings up around it. I had the great pleasure last Thursday to go to Crossmaglen to a family-run GP practice, which was really inspiring, really energising. I will expect no less when Mr Elliott takes me back to the South West Acute Hospital.
Thank you. Colin Jerry Carroll.
Thank you, Minister. Successive Tory and Stormont administrations have wrecked our health service with budget cuts over the years. Given your previous statements about health cuts and a likely new Prime Minister on Friday morning, will you commit to ruling out implementing any budget cuts in the months and years ahead?
Minister.
Well, I thank the member for his question. I think just to be clear, what I've talked about in terms of implementing cuts is that there appear to be 4 categories according to the 5 geographic health trusts, and those are cuts which have low impact, medium impact, high impact and catastrophic impact. And what I have said is that I am not willing to implement cuts which have a catastrophic impact, because that will do real damage to our patients. That represents real, serious, significant and, to my mind, unavoidable harm, and that's not for me.
Jerry Carroll for supplementary.
Thank you, Minister, for his answer. Minister, I would say that all cuts in the health service especially are catastrophic. Minister, there's growing demand for a wealth tax on corporations across these islands. When the new Prime Minister comes here, will you commit to raising it with him as a way to fund our health service? Because millionaire and billionaire wealth is completely out of control, and that's one quick way to fund our health service.
Minister.
Well, again, I thank Mr Carroll for his supplementary question. You're taking me to an area which I think may be just slightly above my pay grade. But I would say this to Mr Carroll. It seems to me that people of reasonably high wealth, with decent incomes, with disposable cash, tend to be taking out private health insurance. So I'm not quite sure where he's going, unless he's suggesting that we impose additional taxation on them to help fund the health service. And if that is the case, that is way beyond my pay grade.
Thank you. That concludes health questions. The Assembly will take its ease while we change over the top table, ready for the Minister's question.